Hello everyone, I'm Paul Healy from the University of Sydney and Westmead and Sydney Eye Hospitals, and I'm honoured to be presenting to you the paper of the month from the Journal of Glaucoma. An important task we face as clinicians is to translate research findings into meaningful clinical information for our patient populations. A good example of this is in the field of MIGS. Trabecular micro-bypass devices, such as the iStent, have been reported to lower intraocular pressure in many studies. But in most of these, patients also had cataract surgery, which we know can also lower IOP. For this study, my co-authors and I asked a simple clinical question. How well does the iStent lower intraocular pressure in glaucoma patients when it is not used in conjunction with cataract surgery? We answered this question by performing a systematic review and meta-analysis of all published studies of standalone iStent implantation, which had more than 10 subjects and more than 6 months of follow-up. We used standardized methods for assessing the literature and weighting each study. We found 13 unique studies, of which 4 were randomized controlled trials, forming a cohort of 778 eyes. These eyes represented a wide range of clinical disease states, from treatment-naive eyes to those with advanced disease, otherwise indicated for glaucoma filtering or tube surgery. And they were split fairly evenly between first and second generation stents. The mean preoperative intraocular pressure ranged from 19.2 to 25.3 millimeters of mercury. For washout studies, this range was 24.1 to 27.3. Mean IOP fell in all studies after iStent implantation. The weighted mean IOP reduction was 31.1% at 6 to 12 months, 30.4% at 36 to 48 months, and 32.9% at 60 months. The pooled weighted mean IOP reduction was some 7 millimeters of mercury, but there was considerable heterogeneity between studies, with individual estimates as low as 1 millimeter of mercury and as high as 11.8 millimeters of mercury. There was a suggestion in the data that efficacy increased with 2 or 3 stents compared with 1 stent. IOP reduction was similar between studies of first and second generation stent and between randomized and non-randomized studies. In addition to IOP reduction, medication burden was reduced by 1 to 1.2 medications across the same time points. Similar reductions in IOP from baseline were observed when stratifying by the number of medications at baseline, which is a reasonable surrogate for disease severity. Variability of pressure outcomes, however, increased at the more severe end of the disease spectrum, which is not surprising. The most commonly reported adverse events were temporary IOP elevation, a loss of best-corrected visual acuity, progression of pre-existing cataract, and cataract surgery. But the incidence of each of these was less than 5%. When we looked at the randomized controlled trials, we found no evidence of a difference in AEs between the treatment and the control arms. In summary, we found consistent evidence for a clinically relevant reduction in IOP and medication burden after implantation of a standalone iStent over a range of glaucoma severity, over a reasonably long term, and with a reasonably favourable safety profile. From a clinical perspective, this means that iStents can safely give us meaningful reductions in IOP for as long as 5 years and delay further glaucoma surgery. Individual pressure reductions, however, do vary, and we need more research to find out preoperatively which patients will have the best and the worst pressure outcomes. If you would like more details about this paper, you can download it from the Journal of Glaucoma website and read more about it on the WGA's social media platforms. Thank you for supporting the Journal of Glaucoma and the World Glaucoma Association.